We have a 10-month-old infant brought with fever for 2 days, cold, crying excessively, and especially while touching left ear of the baby. But remember, important thing is, when you are giving a drug for acute otitis media, amoxicillin base has to be 80 to 90 milligrams per kilogram. Why use only amoxicillin? What is the problem in using amoxiclav? Actually, the cost of amoxiclav is higher than amoxicillin. Amoxicillin clavulanic, is a broader spectrum. Amoxicillin is a narrower spectrum. And most importantly, the side effects like diarrhea, loose motions, etc., vomiting, etc., are much more with amoxiclav compared to amoxicillin. Today's topic, as you know, is drug choice in pediatric OPD. So the title, what we have decided was what, why, and why not. So what do we mean by that? We're trying to say what are our choices and why do we choose a particular drug or a brand, and why do we not choose a particular drug. So in today's session, we will give you a brief case scenario, which will be more or less coming to a diagnosis very quickly. Then we will discuss the available choices that are there for that particular diagnosis. We'll try and discuss what is the drug of choice, what are the alternatives or second line drugs. We'll also touch upon what not to use and why not to use. And apart from the run-of-the-mill situation, if there are any special situations for that diagnosis, we will be discussing. And of course, we will touch upon how to choose a brand or particular combinations once you have decided on the particular compound. Also, if you have to choose from, say, antipyretic, which drug to choose, also we will try to highlight. Let me get started straight away. We have a 10-month-old infant brought with fever for 2 days, cold, crying excessively, and especially while touching left ear of the baby. So obviously, we are straight away thinking in terms of a localized infection in the left ear. When we use the otoscope, this is what we saw. We saw a whitish discoloration, a bulging tympanic membrane, and which was congested and red. So a diagnosis of acute otitis media was made. So as we decided, we will go through this template for each diagnosis and we will discuss them. What are the choices that we have? We have amoxicillin, amoxiclav combination, cephalosporins, azithromycins. What is the drug of choice? So here we will be choosing from either amoxicillin or amoxiclavulanic acid, and why and which one to choose I will be discussing after the second case. But remember, important thing is, when you are giving a drug for acute otitis media, amoxicillin base has to be 80 to 90 milligrams per kilogram of amoxicillin. And for children who are less than 2 years, the duration should be 10 days. And those who are above 2 years, the duration has to be 7 days. If in case this does not work, you have the option of going to a third generation cephalosporin or azithromycin. We will not use oral penicillin or Septran because one, Septran has side effects, and oral penicillins we will be again discussing in the next session. What are the special situations here? If the child has recurrent otitis media, we need to make sure what is the situation. Are we dealing with any precipitating factors like adenoid eustachian tube malfunction or inadequately treated acute otitis media? And it's important to check the hearing and make an adequate ENT referral. One more important point here is that many times you will have a child who comes with ear infection, you have treated, and the child comes back again with an ear infection. So we have to remember, if the child comes back in 15 days of the last infection, then most likely it is the same organism, meaning that has been a relapse of the same bug. But if it is more than 15 days interval, then we say it is a recurrence. So that's a new infection where the organism may or may not be same. Okay. We go to the next case. We have a 4-year-old child, fever for 2 days, throat pain, difficulty in swallowing, no cough. Now you must realize today's topic is on therapeutics, so we are not going to dwell too much into the diagnostics or how and why we came to the diagnosis of a particular condition. So with this particular thing, we are thinking in terms of either a streptococcal throat infection or we are thinking in terms of tonsillitis. So on examination here, we saw this child had a hyperemic tonsillar pilus. The tonsils were hypertrophied, they were hyperemic, and there was some exudate on that as well. Now, we are going to discuss both of them together simply because there is a significant overlap in the treatment modality. Again, the drug of choice, the spectrum that is available is more or less same as the acute otitis media. Now, if you are treating streptococcal throat infection, by its name, it is a streptococcal infection, and hence it will be sensitive to penicillin and is not producing penicillin beta-lactam resistance. So we can use penicillin. There were times when we used to use penicillin. Nowadays, we don't use penicillin often. One, because it's not easily available, the oral penicillin, I mean. And secondly, it's not available in the syrup form, at least in our country. It's also the taste-wise not a great option when you use the dispersible tablets of penicillin. Now here, if you see amoxicillin for acute otitis media, we were giving 80 to 90 milligram per kilogram. Here, 40 to 50 milligram is sufficient. 7 to 10 days, prefers 10 days over 7 days. Now here, if you see, preferably we have written amoxicillin because again, here you are thinking more in terms of streptococcal infection, which does not produce beta-lactamase, and hence only amoxicillin is enough. Now one would ask, why use only amoxicillin? What is the problem in using amoxiclav? Actually, the cost of amoxiclav is higher than amoxicillin. Amoxicillin is broader spectrum, whereas amoxicillin clavulanic, is a broader spectrum. Amoxicillin is a narrower spectrum. And most importantly, the side effects like diarrhea, loose motions, etc., vomiting, etc., are much more with amoxiclav compared to amoxicillin. Now we'll just go back a couple of steps and see why it may be difficult to use only amoxicillin for acute otitis media. Because there you may have other organisms which will be producing beta-lactamase, and that's why you should be giving amoxiclav combination. Also, suppose you have a 15 kilo child and you had to give 90 per kg of amoxicillin. If you do your maths, and the highest strength of syrup available of amoxicillin is 250 milligram per 5 ml. So you will land up giving literally 12 to 15 ml twice a day, which might be difficult to choose. And hence you would choose amoxiclav combination. We'll discuss more about which preparation of amoxiclavulanic to be used when we come to how to choose a brand. Now here in tonsillitis, the second line, if your amoxicillin is not working, in that case you can either choose amoxicillin clavulanic acid or you can use a third generation cephalosporin. Now when we say cephalosporin third generation, please don't use drugs like cefexime. Cefexime is a predominantly gram-negative coverage of a third generation cephalosporin. So choose either cefpodoxime or cefdinir or something on those lines. What not to use? Again, Septran not to be used. Levofloxacin, again, it's an overkill. Also, it can have side effects. And last but not the least, that it's one of the drugs which may be used for anti-TB secondary line, and hence we should be protecting these drugs very vigilantly. Now, in a special situation, you have thought of this as a tonsillitis. We have given appropriate antibiotic, but the fever is still not going. Then you may go to the second line drug, but suppose even now it's not working. Don't go to the third line. Revisit the diagnosis. make sure you are dealing with a bacterial infection and the child has not developed a rash or a hepatomegaly or some lymph nodes, and a diagnosis of EBV may have to be considered. Let's go to the third case. We have a 4-year-old, fever for 2 days, high grade. There is dysuria and increased frequency of urine. Color of the urine is normal and there is no vomiting or abdominal pain associated with that. So what are we talking about? We are thinking in terms of urinary tract infection, most likely a lower urinary tract infection, at least not pyelonephritis, no vomiting, no abdominal pain, child has not been reported to be very toxic, and hence we'll send a urine routine culture and then only we will start with an antibiotic. Remember, there is no urgency to start antibiotic in a UTI. You must collect the sample and send it, only then to start an antibiotic. Again, as you know, you have a whole lot of drugs which you can choose from, and that's where the importance comes. The most appropriate oral antibiotic for urinary tract infection in this particular situation is cefixime. And again, I have highlighted the dose, which will be 8 to 10 milligram per kilogram per day for 7 to 10 days, preferably for 10 days. You will be sending a repeat culture, and then if it shows resistance to cefixime and the child is not responding, then you will consider second line alternatives, which could be an aminoglycoside in the form of amikacin. We will make sure that we don't use ciprofloxacin, ofloxacin, and other bacteriostatic drugs like nitrofurantoin or fosfomycin for a primary treatment or a first line treatment for urinary tract infection in a first episode of urinary tract infection. Now, what are the special situations here? There are a few, so let's go to the next slide and try and see where we need to make different choices. If you suspected vomiting, abdominal pain, sonography showed pyelonephritis, you would not give oral antibiotics. You would admit the child and give a cephalosporin with an amikacin and then wait for the culture and then de-escalate or change the antibiotic accordingly. If this was a recurrent UTI, one would again wait for the culture to come through, not in a rush to start an antibiotic, and try to find out the cause of UTI, which could be like in the next one, which says VUR. So if there is a VUR, then you need to make sure that it is more than grade 3, in which case only nowadays a urinary prophylaxis is required. Now here, a nitrofurantoin is a great drug to use, provided the child is not G6PD deficient. So here we need to give only a single night dose, which will give good coverage and protection against a urinary tract infection. But a child is born with a congenital kidney or urinary tract abnormality, like a PUJ obstruction or a hydronephrosis, and you are doing the workup. Till the workup comes through or the workup says that you need to protect against urinary tract infection, below 3 months, we do not like to use nitrofurantoin. So we would go for a drug like cephalexin. And in case recent antibiotic course has been done, then you should, for any other urinary tract infection, any other reason than urinary tract infection, please again wait for the culture before you make a choice. So to recap, in urinary tract infection in children, first episode, relatively non-toxic child, give oral cefixime 8 to 10 per kg per day for 7 to 10 days after sending urine routine and clean catch culture sample. You may not wait for the culture report to come here. You can adjust your drugs accordingly later on. Let's go to the next one. You have a 6-year-old child. Fever started gradually, is now increasing. Fever is continuous, though the parent says that fever jata hai, aata hai. But that is because the child is being given antipyretics every 4 to 6 hours. So the fever is controlled with the antipyretic effect. And as soon as the effect goes, the fever comes back. And there are occasional chills also since last 2 days. Child also complains of few soft stools and pain in the right hypochondrium. On examination, you have a soft 3 centimeter liver, may be palpable, may be tender, may not be tender, and there is no spleen. So here we are making a diagnosis of probably an enteric fever. We have now sent a blood culture along with CBC, and we are going to start an antibiotic. Remember, even on OPD basis, a blood culture is money saving investigation, because once you have a blood culture sample sent and you get the report positive, even if the fever doesn't subside in 2 days, 3 days, you have time to wait. The parents will have more confidence, you will have more confidence, and you will not be running around doing tests like CT scans and ultrasound and repeat blood tests, right? So here again, we have a long list of drugs to choose from. I'm not going to read all of them because you know them. The important thing is here again, the dose, the drug of choice is cefixime. But you see here, the dose is different. The dose, instead of 8 to 10 per kg, we like to call it enteric dose. So basically it means high dose cefixime, 20 milligrams per kilogram per day for at least 10 days, or at least for 5 days after the fever has subsided. So it could be 10 to 14 days also. The important point to remember here is, because we get syrup of only 100 milligram per 5 ml, we are hesitant in giving a much larger dose to a child who is, say, a teenager. But remember, in adult, maximum dose here is 1200 milligram per day. So don't hesitate to give 630 kg child 600 milligrams of cefixime, because otherwise you will be underdosing the child and you may not get the adequate response. Now here, as a second line, only if your culture is showing something different or the child is not responding, you will add azithromycin. I know there are newer reports which says resistance to cefixime and azithromycin should be added along with cefixime, but I feel personally that we should start with cefixime. Most of the time you will get away only with cefixime. But if the child is not doing well and the child's fever is jumping, the baby is not responding, hydration is poor, in that case it is better to admit and start the child on IV ceftriaxone. What not to be used? Many of us have used chloromycetin in the bygone era, and I would like to still say bygone era, because chloromycetin is not worth taking a risk. One can land up with a very bad aplastic anemia, and it's just not worth it with the current armamentarium that we have. Again, ciprofloxacin, ofloxacin has been currently proven to be not effective against salmonella in our country. Similarly, Septran only in very few cases, and that too we have these two drugs which I mentioned already, which should be used. Special situations, relapse. So many times we wonder, it is relapse, should I change the antibiotic? No. If you think there is relapse, send the culture, see the culture report, and then only choose an antibiotic to start. I have made a mention here of special situations where pets like turtle, etc. also are there in the house. Now here you may get some labs will report salmonella or something like that, but this would be a non-typhi salmonella, and there you would have to give ceftriaxone for a much longer period of time, being a zoonotic condition and not your standard salmonella typhi. So next we go on to case number 5, and that's a 6-year-old been vomiting for 2 days, now better. Loose motions has been there now for another 2 or 3 days. They are watery, large, foul smelling, but there is no blood. Fever has been there for 3 days, hovering around 100. Mild abdominal pain and cramps. So a diagnosis of gastroenteritis has been made and not of dysentery. I have just written dysentery here so that we can debate of gastroenteritis versus dysentery. Now, if it is gastroenteritis, what are your choices here? So you see here I have not written antibiotics in the choice of drugs as well. So here the choices are, you give ORS, hydration, zinc supplement and probiotics. These are your choices. What's the drug of choice? Ideally, I should have written like some of the cereals, ORS, ORS, ORS. But let's face it, ORS plus zinc is also part of the recommendation. So ORS and zinc would be the drug of choice. For patient satisfaction or for our satisfaction, or half the time the patient would have already started on probiotic, which is fine. The only probiotic which has been shown to be significantly making a difference is a probiotic containing LGG. All the other probiotics are supposed to reduce the duration by not more than 24 hours. But what is not to be used? So please don't use antibiotics. Please don't use resicadotryl. And when I say antibiotic, purists will say antimicrobial should be used because people would still use metronidazole. So do not use that. So what is the special situation? If you have blood, mucus, small sticky stools, high fever, pain in abdomen, cramping, then you would think in terms of dysentery, which could be by enteroinvasive E. coli, or it can be by Shigella or any other gram-negative organism. And there again, you may use cefixime. If the child is very sick, you may think about getting him or her admitted and giving amikacin. A small mention here, if you get only blood and mucus, the child has no fever, you might be dealing with a Shigella toxin situation where sometimes giving an antibiotic may increase the risk of HUS. So again, you need to be careful in a child with gastroenteritis looking like dysentery but without fever before you give an antibiotic. In pediatrics, there are very few occasions where you will have to use metronidazole for diarrhea. For acute diarrhea or acute dysentery, please do not use metronidazole and definitely not use a metronidazole combination. So now we have discussed about 5 cases and we are almost halfway through our time. Let's choose a brand. So once you have chosen a drug, you want to select the appropriate brand. So how do we choose? And we don't definitely not choose by the most friendly MR that visits us. We will have our own ways and methods by which we will choose. So let's talk about the formulation. When do you use drops? When do you use syrup? And when do you use tablets or capsules? So obviously in small infants, and very small children, you would prefer drops because they are concentrated and the quantity required is smaller. Also, you can titrate the drops slightly better if they are ml wise composed. Syrup, on the other hand, for everybody who is little more than 1 year till they start taking their tablets. Amongst the tablets, as soon as they're able to swallow, you would prefer to give tablet. But sometimes you have underweight teenagers where titrating the dose may be difficult with a tablet. So there you may either use a dispersible tablet which they can swallow, or you can use a syrup, preferentially over a tablet. Dispersible tablets are very good because they give you accuracy in dosages after dissolving compared to syrup. But the palatability and the taste wise, syrup is much better. Even the dose titration wise, syrup is much better. The all important thing according to me is the taste or the palatability of the particular formulation. If the taste is not good and the child is not going to take it, there is no point in attending this lecture or prescribing the patient because the patient is not going to take the medicine. The other thing is the availability. Please don't write a brand which is available only at one particular chemist, and especially if it's available only at your neighborhood chemist. Make sure it is freely available and accessible by the patient. The third thing is about storage. So people who are working in resource limited areas, we have to make sure that whether this has to be stored under refrigeration or if it's a dry powder versus a ready mix, which need not be stored under a specific condition. Also, certain companies claim to have higher shelf life compared to others. So that also makes a difference in which brand will you choose. The other important thing is which product you are familiar with. So you would know how the label looks like, what is the taste, what is the color. So even when you are talking with the patient, you can make sure that they are taking that particular thing. And lastly, this LASA, LASA is the word abbreviation used for look alike, sound alike drugs. So what policy we follow here is, I will give you an example. Suppose Cherikov, Ascoril, Sinarest, Timinic, they have at least 5 or 7 formulations under that one particular catch name. So I would not use more than one type of Cherikov. So if I'm using Cherikov, I will not use the LS, the junior, the whatever, etc., etc., etc. So that I know when I talk with the patient, even on phone, that Cherikov only means that particular formulation of Cherikov. Okay? And by the way, this is not sponsored by Cherikov. Okay? So next we come to combinations. So how do we choose combinations and why do we choose combinations? When you choose a combination, few things we need to check. Whether they are in correct proportion. Meaning for 10 milligram, for a milligram per kilogram dose, they have to be in the correct proportion. They have to be having the same frequency of dosage. And most important, they should have common indications. So classically, if you have a dextromethorphan with sodium citrate, that doesn't make sense at all. And I believe there are some 32 more drugs that the government has recently banned, the combinations that they have banned. But there are some useful additions like amoxiclav. Now, when you choose a brand or a formulation in that, you need to check the strength and the composition. Because when you give 80 to 90 milligram of amoxicillin, you do not proportionately increase the clavulanic dose because that will give rise to increased incidence of diarrhea. So when you are using an amoxiclavulanic acid combination, say for example for acute otitis media, you would rather use a 600 milligram per 5 ml with 25.7 milligram of clavulanic acid compared to somebody where you would want to use 200 milligrams of amoxicillin with a 25 milligram of clavulanic acid. So to repeat, when you have to give higher dose, increase the dose of the amoxicillin, not increase the dose of the clavulanic acid. So choose your drug appropriately. What to avoid? When we say what to choose, we must also know what to avoid. Please don't use ibuprofen paracetamol combination. Why do you want to hit 2 bullets at the same time? It's not like one is going to miss the mark and other is going to hit the mark. If you give ibu and para together, you have no medicine left with you to give for the next 6 hours. Rather, you give paracetamol. If need be, if paracetamol doesn't work, then and then only you need to use ibuprofen. Similarly, mefenamic acid and paracetamol should not be used for the reasons that I mentioned above. Plus, all of us have been given this vague idea that mefenamic acid is safer than ibuprofen. Why? Because there is a whole lot of literature outside which says ibuprofen can have A, B, C, D problems, but not with mefenamic acid, which is actually not true. It's a bit like ostrich in the sand kind of a thing. Because mefenamic acid is not used as an antipyretic abroad, there are no studies to tell you about the side effects. We all have seen enough problems with mefenamic acid to not use it. Personally, I would prefer to use ibuprofen over mefenamic acid anytime. And similarly, if you see the last one, azithromycin plus cefixime, you know we saw a few indications where you may add one after the other. But there is no need to start with the combination. And simple reason is cefixime is given twice a day, azithromycin is given once a day. And the dosage composition and proportions are also not going to be same. So with this, we have now learned how to choose a brand once we have chosen the drug. So let's address a few more conditions. A 7-year-old child comes with fever for 3 days, chest pain, minimal cough, breathing fast, and tachycardia is out of proportion. So here you see the fever is there, but the tachycardia is out of proportion. Even if the cough is minimum, but if the tachycardia is out of proportion to fever, please consider this like an inflammatory response and a potential source of infection in the body. When we did the X-ray, this is what you saw. So you saw a right-sided consolidation. This child has been having fever, breathlessness, and chest pain. So the diagnosis of consolidation was made. We know the common drugs that to be used. The drug of choice is amoxiclav or amoxiclav plus azithromycin, depending upon whether you are expecting a mycoplasma atypical infections or not. Sorry. Here, if the amoxiclav does not work, so how do we know it's not working? A repeat X-ray is not going to show you clearance very quickly. So the typical time for defervescence in a consolidation is 72 to 96 hours. Or of course, if there is deterioration of the clinical condition before that. So in which case, you will think about either changing the antibiotic or thinking about why this pneumonia is getting complicated or not responding. Again, what to not use? Many times teenagers are prescribed levofloxacin, so please don't use that. Again, we want to keep that drug safe. Linezolid, if it is suspecting a severe MRSA infection, better that the child is hospitalized and treated. And again, ferropenem, I haven't used in my OPD practice ever till now. Just a quick mention here, it is not a step down for meropenem, right? So if you have to give meropenem for some other condition, for some other reason, make sure the patient completes that and don't think about changing to oral ferropenem in that. It's not like a step down from ceftriaxone to cefixime kind of story. So what are the special situations? Now, if you thought that the child was not so toxic or not willing to admit, but you are thinking in terms of staph, the counts are very high, the CRP is going haywire, and you are worried about it. So you will add oral cloxacillin. Fortunately, this lovely drug, which was not available for so long, is now again available as a standalone cloxacillin syrup. So you can add it to along with amoxicillin and cloxacillin, or you can use it along with any other drug. Now, this child did not respond. And after 3 days, we did a repeat X-ray, which showed this kind of cavitation, bullae formation, and a strong suspicion for staph was thought about. So these are some of these anti-staph drugs that one would consider. But here again, the child who is not responding to oral antibiotics, make sure that the child is admitted and started on appropriate antibiotics. One would think of giving vancomycin with or without clindamycin. A quick word about clindamycin here. We don't routinely use it in pediatric office practice, but in ICU, in admitted patients, when you are thinking about a high toxin producing MRSA in the form of community acquired MRSA, with suggestive because of extremely high CRP in 3 digits or more, and in very high WBC count, and the child who is very toxic, clindamycin works very well because it neutralizes the toxin and prevents damage to the lung tissue. On the other hand, you have another scenario, the same patient, but X-ray to start with only was looking like this. So here, if you see, there are increased bronchovascular markings bilaterally. The child had plenty of cough compared to less cough, and there is no chest pain compared to chest pain before. And if you see here, there is what is known as tree bud appearance, or simply remember that there is no consolidation, but more increase in vascular markings. So and this is a school-going child, typically you would be thinking of atypical infection and mycoplasma, so macrolides would be considered. Now we need to decide whether you want to give azithromycin or you want to give clarithromycin. Okay, I'm sorry, it says clindamycin, I should have written clarithromycin. Azithromycin versus clarithromycin. Both are macrolides, both can be used. The subtle difference being clarithromycin has a higher risk of QT prolongation, has a higher risk of drug-drug interaction, is slightly less palatable. You have to give more frequently. But the flip side is, it is evidence-wise a shade better than azithromycin as far as the lower respiratory tract mycoplasma is concerned. So you can take a pick. And if you are going to give bronchodilators along with that, or if the child is on anti-epileptics, then please avoid clarithromycin and stick to azithromycin. Why we have written doxycycline here? Because recently there are some cases of mycoplasma resistant or non-responsive to macrolides. But again, please don't jump to conclusion on this. Majority of our patients that we see are going to respond to azithromycin, and these are going to be a very rare situation where they have either taken earlier or they have any other immunocompromised state, etc., etc. In which case, doxycycline can be kept in mind. Again, a pointer here for doxycycline. We have always been taught that doxycycline should not be used for below 10 years, below 8 years because of the permanent teeth being stained because of that, which has now been ruled out. Not only when we use it as a single drug for exposure to leptospirosis, but also when we give a full course, it is supposed to be safe provided your indication is appropriate. Do not keep adding higher antibiotics if pneumonia does not respond. Look for complication, look for atypical presentation, and look for any situation which is causing decreased mucociliary clearance or any congenital abnormality of the lung or any functional or physiological problems like GER. So the golden rule remains that if you decided or started on an antibiotic, you change the antibiotic to second line. You remember there is no such thing as third line antibiotic, because in the third line you have to revisit and make sure that whether your diagnosis is correct or whether the host is correct or whether the organism is appropriately responding. Next, we go to case number 7, a 10-year-old with swelling on the left side of the neck and fever for 4 days. It's tender, erythematous, soft, non-matted. Life is simple. No organomegaly, no Cox contact. Unfortunately, in real life, you won't have such crystal clear situation, but today we are discussing these. So we are thinking in terms of bacterial lymphadenitis. And then our drug of choice are amoxiclav, a cloxacillin combination, or a cephalosporin. Again, amoxiclav is preferred. We do not want to use azithromycin or levofloxacin for a slightly different reason. One, because levofloxacin, as we have said multiple times, we want to save it, but also because this could be an NTM, right? Non-mycobacterial tuberculosis. So you don't want to give a drug which is used for that because you will mask the diagnosis. And again, when we say third generation cephalosporin, please don't use cefexime. Cefexime should be used where you are expecting gram negative. Otherwise, use antibiotics like cefpodoxime or cefdinir for this. If there is non-responder, make sure you rule out other diagnosis. So get a biopsy done, get an aspiration done, preferably a biopsy. Make sure you examine the patient again, see for new signs and symptoms. Rule out lymphoma, Kikuchi's disease, other malignancies, etc. You have a 3-year-old boy, noisy breathing, irritable, 100-degree fever. He is not known to be a wheezer. Comes at 4 a.m., 5 a.m. on a winter morning, and you get a call that this child has come. This is your diagnosis, telephonic diagnosis of croup. How do you treat? There are various choices. You can comfort the child, you can give steam, you can give warm air, epinephrine, steroids, hyperneb nebulization, steroid nebulization, etc., etc. The decision will be made on whether this is a mild, moderate, or severe croup. If it is a mild croup, then also, apart from calming the child, not making the child cry, etc., make sure a single dose of 0.15 milligram of dexamethasone, if not available, 1 milligram per kilogram of prednisolone. It should say prednisolone here. I'm sorry, it's not written here. Should be given. Why we have written prednisolone? Because though dexamethasone is superior, in syrup form, prednisolone is much easily available. So we tend to use that. If it is a moderate croup, then definitely choose to use dexamethasone, and give a higher dose. You can go up to maximum of 16 milligram, and simultaneously give epinephrine nebulization. In severe case, obviously you will be straight away admitting and keeping him in the ICU and managing. Please do not give antibiotics, do not give bronchodilators, they are of no value. If the child is less than 6 months or above 5 years, I remember it like a febrile seizure. So if they are out of these two range, make sure that you are dealing with croup only, because this is not the typical age group where croup presents. And if the croup doesn't respond to your steroid or as expected, please make sure you rule out foreign body and other congenital abnormalities which may present like croup. A 10-year-old child, fever for 4 days, irregular chills and spleen palpable. We made a diagnosis of malaria. Again, we have multiple choices here. I would say if it is Vivax, please use chloroquine. If it is Vivax plus falciparum or only falciparum, use artemether lumefantrine. Do not forget to give primaquine as soon as you checked G6PD. If G6PD is deficient, change your primaquine course appropriately. If the child doesn't respond and you have given chloroquine, you may do the test again. And here, when you repeat the test to see for non-responders, make sure you choose the correct card test, or even better, go for a very good smear examination. Because a good smear examination will pick up a relapse for sure. It will be helpful in finding the appropriate species, as well as it will give you parasitic index. So don't cut corner, and in case of non-responders, don't just take only the card test. Special situations, as we mentioned, G6PD deficient patients, you will not be giving chloroquine. You may give only artemether lumefantrine and follow it up with a once a week high dose primaquine with close monitoring of hemolysis. Pregnancy, lactation, and prophylaxis, I think we can look at it at some other time. Ideally, in India, we do not recommend prophylaxis for people who are traveling from outside and they come here, because now at least we don't have that bad malaria situation. Lastly, we'll talk about conjunctivitis. It's a very common scenario. The moment the eyes are red, we want to prescribe an antibiotic drops. But please don't do that. This is a very nice diagram which we have picked up from Up to Date. You see here, no discharge, red eyes actually make me worry more than discharge and red eyes. Because apart from it being a harmless allergic condition, a painful red eye without discharge is a much bigger problem. It could be uveitis, it could be glaucoma, it could be trauma, etc. So that you need to rule out. If there is significant discharge, like the first image here on the left, you are talking about bacterial conjunctivitis, and you will give antibiotic drops. Very young children, please give antibiotic ointment because they stay longer and it is easier to apply. When you are not sure that there is enough discharge or not and it's viral, you can wait for a day or two, provided you have ruled out the red flags. So what are the red flags that you have ruled out? There should be no photophobia. There should be no vision disturbance. Mild pain can be there, but it should not be a significant pain. Neosporin, tobramycin, moxifloxacin, you can choose any one of them. Ophthalmologists, all of them have their own views on that. As far as Dexa or Fluoro are concerned, my rule is not to give any steroids in conjunctivitis unless seen by an ophthalmologist. Because if you are dealing with a herpes virus conjunctivitis, you will end up giving steroids, or you have any other condition and you have given steroids, you will be in trouble. The difficult situation would be a newborn. A different situation would be newborn with conjunctivitis, where obviously you will think about chlamydia, or you can think about gonorrhea. Okay, so these are the two different situations. And as we already mentioned, red eye without discharge is a potential danger. Now we have touched upon how to choose a brand, but suppose you have to choose a drug amongst the group of drugs. How do we go about it? So let's quickly look at that. Antipyretic. Suppose you want to control fever. What do? Use paracetamol as much as possible. Use ibuprofen when paracetamol is not enough. Do not use mefenamic acid. Do not use any other NSAIDs. Do not use steroids, please. Do full body sponging. If the child is unable to take oral, consider rectal. If the fever is very high, there is high risk of seizures or past history of febrile seizure. Think about getting the child under super observation and think about giving IM, etc. About NSAIDs, again, preferably use only ibuprofen. In certain rheumatological conditions, one would use naproxen. And I have written diclofenac because in our country, unfortunately, diclofenac is one rectal suppository available. If the child is not taking orally or vomiting persistently, and you don't have the facility or you don't want to give an intramuscular or intravenous product, then diclofenac can be used correctly. When you're choosing an anti-allergic, you need to decide whether you want to give a sedative or a non-sedative. Younger children, not very young, but younger children, I don't mind giving sedative because a little bit of sleep always helps them recover faster. So any CPM, hydroxyzine or diphenhydramine are all good. Non-sedative, cetirizine and fexofenadine, though many patients say that cetirizine is sedative for them. So that I would put it somewhere in between. Again, when you combine two antihistamines, be very careful. Don't combine cetirizine with hydroxyzine because one is the metabolite of the other and you will end up getting overdose situation there. Please don't use decongestants and cough suppressants till 4 years of age. The government has also put a ban recently on the decongestants. And we had tragedy from Delhi with dextromethorphan overdose in young children because of wrong prescription or because of wrong amount taken by the parents. We would never know. So still, to be on the safer side, avoid giving cough suppressants to children below 4 years of age. We touch upon topical steroids because that's something else that we use in our office practice. So remember, in increasing potency, so ointments are more potent, generally speaking, than creams, and creams are more potent than the lotion. Also, you choose ointment when you want to give more coverage and protection on the skin. You avoid using ointment on the hairy areas. You avoid using ointment on the face. Whereas lotion, on the other hand, you use when you want to cover larger area. And cream is everything in between. When we are talking about potency, if you see here from blue to red, it is in increasing potency of topical steroids. And believe me, I have not taken all of them because it will just confuse you further. I would remember it this way. Hydrocortisone is the sweetest of all. Desonide is the another one which can be used for smaller babies without much problem. Mometasone and fluticasone are medium potency. Betamethasone, valerate is somewhere in between, like high but not very high. And betamethasone dipropionate. So why I put these both over here, it's not just enough to know the first name, you must know the surname as well in order to be sure where you are dealing with. Finally, clobetasol propionate, like I won't use the brand names because I'm going to say do not use that product in pediatrics at all. So when I'm going to say don't use it, I don't want to give the brand name. So now one sentence only. Impetigo and soft tissue, skin and soft tissue infection. Please use first generation cephalosporins like cephalexin and or cefadroxil, and that would be good enough. For hand, foot, mouth, do not use an antibiotic. Use any Caladryl, lactocalamine, some such soothing agents. Give an antihistamines if there is itching, and give some gel to soothe the mouth. Dental infections. Generally, dental infections will have anaerobic flora of the mouth and closed infections. So use amoxiclavulinic acid. Some dentists prefer to use ornidazole or metronidazole along with that. That depends on the severity of the infection. Bites, human bites, again, only amoxiclav. If it is animal bites, and depending on the animal, you may want to look at what antibiotic you're going to give, but make sure that you give appropriate immunization if it's a dog bite or a cat bite. Scabies, single dose application of permethrin, enough. If you are not sure, then you can use ivermectin, and these two together will be able to take care of scabies. Finally, to stop here, how do we choose? We choose the drug which is the narrowest spectrum, which is going have very high efficacy, very high safety. The dose and the duration are appropriately selected depending on the condition that we are using for. Make sure that you are looking at any special situations. Taste and cost are very important. If you are using combination, make sure that the frequency, quantity, etc. are matched appropriately. Whenever you prescribe a medicine, we are dealing with obesity day in and day out. Make sure that you are not overshooting the maximum dose, that means the adult dose, and always look for contraindication. Finally, this should have been the first slide. Primum non nocere basically means first do no harm. So if you don't know what you are dealing with, if you are not sure what you are going to do, you can tell the patient, wait, let me check and come back to you. Or let's get this test done and I'll start an antibiotic a day later. Except for things like pathogenic meningitis or meningococcal infection, hardly any infection is going to be such that you can't wait for a few hours or a day to give antibiotics. Thank you very much. Thank you, Dr. Barsha. I am done for the day.
For that wonderful talk you have delivered. I see a lot of doubts coming in from our doctors. We will be getting into that. Dr. Reddy had asked, so fever, can we use azithromycin as IV alternative to ceftriaxone?
Yeah, so as Astronome or any other higher antibiotics are used only if your ceftriaxone is not working and the culture is saying that it is salmonella which is resistant to ceftriaxone. We were talking about office pediatrics, so I'm not getting into an ICU situation or non-responding IV ceftriaxone.
Next, Dr. Chakraborty asked, how long azithromycin can be given in enteric fever and at what dose?
So azithromycin again is given at a higher dose than the regular dose, around 20 milligram per kilogram per day, and 7 days to 10 days you can go up to that.
The next question from Dr. Rajashekar. So if a child of 1 year old diagnosed with anemia, HB 6.5, what kind of management can be done apart from oral supplements and nutrition?
So oral supplements, I mean, I understand that you are saying that you will be giving a good amount of 5 to 6 milligram per kilogram of elemental iron in appropriate dose and it is being absorbed, etc. In that case, and you do not want to investigate, there are no red flags against a nutritional anemia or iron deficiency anemia that you are thinking, and you have started this only on basis of CBC, which is suggestive of iron deficiency anemia. In that case, I would wait and see in a month's time and see whether the child's activity, appetite, etc. has increased or not, and repeat the CBC after a month to see that I'm getting a good rise in the hemoglobin or not. But if there are any other red flags, then obviously the whole discussion would go on what are the other causes for a 6.5, which is quite low for a 1 year old child on just iron deficiency
Next, Dr. Rathod asks, so for zinc, can we use Renifol Z syrup?
Yeah, brand names are okay to use, then I would say you can use because Renifol Z has double dose of zinc than Renifol, so you can use that. Yeah. If you want to give probiotic and zinc together, you can use that. See the problem. See, we are talking practical stuff here. I'm not going to be talking about what only the evidence says, because zinc. The only problem with zinc syrups is that it's not very good in taste, and the child who is already having loose motions or vomiting, the acceptability of zinc, plain zinc preparations, is not the greatest. That's the problem.
So, another question from Dr. Rathore was, sir, plain cefixime or cefixime CV in dysentery? Also, what will be the dose?
So again, it's a good question. Cefixime CV you can use if you are thinking in terms of, again, beta lactamase producing, but there is a whole lot of discussion that it's not as appropriate as amoxiclav, because in gram negative you can have extended spectrum beta lactamase where your CV is not going to work. So whether to use only cefixime or cefixime CV is a matter of discussion. I personally use only cefixime. I do not use cefixime CV.
Next up, Ahmed is asking, children repeat fever every month, and what diagnosis should be given?
And that's a fairly broad question, I would say. Means if it was like an MCQ in an exam, I would say if it's exactly every month, then I would look for aphthous ulcers and lymph nodes, and then I would say this is like a periodic fever situation and give steroids and it becomes okay. But if you are getting fever every month, I would more commonly think about why the child is getting fever every month, whether it is the same upper respiratory infection, whether it's a repeated viral infections, whether it's a UTI which is coming in, and so on and so forth. So I don't think I can answer that this question upfront saying what are the causes. I mean, there could be many causes. How long does the fever last? Does the fever come and go away in 2 days' time without treatment every time? And you are dealing with probably with us with only with viral fevers.
Next question from Dr. Sajidul. If the children is allergic to NSAIDs, what can be used in fever?
Paracetamol and sponging. Believe me, paracetamol and sponging can take care of fever, of any fever. It's just that our, and when I say our, I mean mine as well, our impatience or our insecurity, along with parents' insecurity about handling.
Next from Dr. Gajria. Dose of doxycycline per kg. Also, from what age onwards can we give?
Yeah, so that's what Dr. Ajay, I just clarified that previously we were giving only above 8 years, but now the new data says very clearly 2 to 3 milligram per kilogram per day. And we can check this dose once again. And right from, I think, 1 year or even younger than that, you can use. That's the new recommendation, but only for very select cases. Okay. And we not going to use doxycycline like we used to use tetracycline before or stuff like that.
So next from Dr. Rathore. For viral conjunctivitis, eye drop should be used.
So ideally for viral conjunctivitis, no drops required. Only you can give medicine for, say, like a refresh or something like that. For allergic conjunctivitis, again, you can use systemic as well as something like olapatidine, but not steroids. As I said before, I have made it a rule to not prescribe steroids without consulting an ophthalmologist in children for eyes, for any conjunctivitis.
Next, Dr. Reddy says, drug combination dosage should be calculated in that combo.
Both drug dosages should be calculated. So for example, if you are using montelukast and levocetirizine, right? We didn't touch upon that today, but you have to make sure that both levocetirizine for a 10 kg child and the montelukast for 10 kg child is appropriate in that. It should not be that montelukast dose is like for a 20 kg and this is for 10 kg, and then you will give somewhere in between. That's not a very good combination to choose.
Next question from Dr. Choice and cellulitis.
So when you say cellulitis, if it is just a cellulitis, meaning whether there's a minor injury or injection related or scratch or abrasion, etc., first generation cephalosporin, cephaloxin, or cefadroxil are good enough. If there is break in the skin, you might consider amoxiclav. But if you are dealing with a major injury and something like necrotizing fasciitis, etc., or a very bad wound, open wound, then you definitely need to get the child hospitalized, and you will have to give cover for anaerobic uh, bacteria as well as gram positive as well as gram negative, because they can have a polymicrobial contamination.
Next, Dr. Praveen asks, how do we differentiate between viral diarrhea and bacterial diarrhea?
Very nice. So we say viral diarrhea and bacterial dysentery. That's the first differentiation we must make. When we say bacterial, it has to be dysentery only. And for all practical purposes, I would go ahead and say if there is no blood, there is no dysentery. Because Nelson's definition of dysentery says blood in the stool. So we are not talking about inflammatory bowel disease or ulcerative colitis or thinking of those things, mixing them up with this. We're talking about acute diarrheal condition. So it could be acute viral diarrhea or acute bacterial dysentery.
Next from Dr. Ahmed, how do we treat adenoid in 4-year child?
So, okay. So adenoid, it's like appendix. Everyone has appendix, everyone has adenoids. When there is adenoid hypertrophy, we have to decide how much is it altering the child's lifestyle and what are the potential dangers. And depending on that, you will have to treat. So if there is adenoid facies developed, if there are ear infections, if there is snoring, and if there is attention deficit through the day, daytime sleepiness, all or most of them are there, then you'll have to think about getting an ear evaluation done, getting an ENT, and think about getting a surgical done. If you're thinking about surgery, classically they say you require to have 4 or more justified antibiotic courses for adenoid infection before you can think about the surgery. Not evidence based. Many of us use, including me, nasal steroids and antihistamines for adenoids, but there is no great literature to support it.
Taking the next question from Dr. Sun, how do we know if a child is allergic to a certain antibiotic? And also, how is the test dose calculated?
So we don't give test dose routinely for any antibiotic unless there is a past history of an allergy. Now, allergy can be IgE mediated, non-IgE mediated, all the 4 types of IgE allergies which are there. But in short, orally, if you have taken something and developed a rash, vomiting, severe cramping, abdominal pain, or even worse, like anaphylactic or anaphylaxis, where there is puffiness of the eyes, face, lips, difficulty in breathing, hypotension, so then you would definitely consider it like an allergy. Or if there is a fixed drug reaction, which you know that after taking this drug, this reaction happened, and again next time they took it and a similar place, a similar reaction happened, then you say it's drug allergy. And other than the test dose, we would rather avoid that particular class and similar class of drugs, including antibiotics.
Next question from Dr. Purohit. What can be given to a child below 4 years for cough with rhinitis?
So, this will depend primarily on the duration of the condition. So, initially, you would be thinking of this as probably a viral upper respiratory tract infection. By definition, if it goes on beyond 7 to 10 days, then you will have to start thinking in terms of rhinosinusitis. And when you think of rhinosinusitis, if it's acute viral rhinosinusitis, you may not give any antibiotics. But if it is acute bacterial rhinosinusitis, means there is fever, headache, and cough and rhinitis, then you will give amoxiclav or amoxicillin for 7 days.
Next up, everyone is asking, is chloroquine also contraindicated in G6PD deficiency apart from primaquine? Also, what should be the alternative for primaquine in such cases of G6PD deficiency?
Yeah, so I did mention actually, I was running fast probably. Primaquine in G6PD deficiency in patients with P. vivax infection, the WHO recommends to give a higher dose of primaquine once a week only, and not for every day for 14 days. So once a week for I think 2 weeks or something. I don't know, 2 or 3 weeks. I don't remember exactly how many weeks. The idea being that you give a large dose, give single time, but you will be able to observe the patient rather than giving multiple exposure daily where the chance of hemolysis cannot be monitored.
There's still a lot of questions that are coming in. Can we take a few more?
Sure.
So next is from Dr. Archana. Newborn baby, can we use antibiotic for redness and mucoid discharge from eye?
Yeah. So again, as I said, if it's a newborn with mucoid discharge from the eye, rather than thinking of routine bacterial infection, we have to think about chlamydia and we have to think about gonorrhea. And depending on what we are dealing with, we can check the mother and then we can use appropriate antibiotic. There are erythromycin ointments available which you can use for chlamydia. And say we used to use silver nitrate before, but now we don't see so many cases of gonorrhea.
So next, Dr. Mittal is asking, can typhoid vaccine be given to a child who suffered enteric fever and treated a month back and now is asymptomatic?
Sure, we should be giving. Can be given and should be given if they have not received a previous typhoid conjugate vaccine.
Next, Dr. Shirsagar is saying, if the child is allergic to paracetamol and ibuprofen, what drug should be used?
I haven't come across one till now, thankfully, but I don't know what I would be doing. I would be advising only sponging because if ibuprofen are allergic, you are likely to be allergic to all the other NSAIDs. See, other thing about allergy, no, sorry, the other thing about allergy is like for penicillin or sulfa, everybody has a fancy to say, I have allergy to sulfa in the family. I have family history of penicillin allergy. We must get into details exactly to find out what kind of allergy it was, what was the causal relationship with the offending drug, etc.
So Dr. Kulkarni is asking, which is lymphadenitis?
So this is the commonest ultrasound diagnosis that you see, non-specific lymphadenitis. The word itself is non-specific, so you don't need to treat. No antibiotics.
Dr. Naveen is asking, if clubfoot is rectified in age of 2 years, is it recurrent in future?
No, I don't think so. Unless you are dealing with a neurological clubfoot for which you will need surgical correction, etc., then you'll have to follow up more closely. But otherwise, it should not. If it's rectified at 2 years, then there is definitely no need to worry about.
Next is from Dr. Panwar. What is the drug for UTI?
Oral drug for UTI without any complications would be cefexime, 8 to 10 milligram per kilogram per day for 7 to 10 days.
So Dr. Patel is asking, only single episode of blood in stool can be considered dysentery?
Yeah, so this is a very good question actually. Even with gastroenteritis, one can have one single episode of blood. Now, when we say blood, what does it mean? It can mean many things. If it is just a spotting over there, or if there is a little clot of blood which has come out, it could be because of fissure or because of passing acidic stool. There is ulceration. Then there is this. Sometimes because of vigorous cleaning, also they will have little bit of blood spotting. That is not called dysentery. Dysentery will be blood and mucus mixed with stool. If it's a separate blood coming out, we are thinking more of lower GIT problems, whether it's fissure or whatever other things that
Next, Dr. Mohammed is asking, which antihelmintic is best for a child under 6 years?
Albendazole 400 milligram single dose. and we don't need to give every 6 months. That's a WHO recommendation for universal deworming for patients who otherwise are symptomatic. We can use it.
Dr. Vinay says, extraperitoneal adenopathy, what is the significance?
So again, adjust adenopathy, as I mentioned earlier, if it is the size, the subcentric lymph nodes, we don't worry about it. If they are necrotic, if they have a particular type of oval shaped with hilum, which is abnormal, etc., then you think about various diagnoses of tuberculosis or malignancy or something like that.
Next, Dr. Bhushan Agarwal is asking, so how do we treat cholelithiasis and nephrolithiasis with medicines in a 7-year-old male child?
I think this will be a surgical discussion. I'll skip this question if you don't mind. Because this will depend on the cause. So basically, if you have cholelithiasis, as a medical person, I would look out for why the cholelithiasis occurred in a 7-year-old. So I'd be looking at hemolytic anemias and things like that. For nephrolithiasis, I would think about why is there nephrolithiasis. Treatment-wise, it would be surgical if symptomatic.
So the next question from Dr. Pravin, treatment of mesenteric lymph node.
I think we addressed that right now. The abdominal lymph node.
So doctors, maybe we can take the last 2 or 3 questions
Sure.
for tonight. Yeah. So another question from Dr. Agarwal was, since antibiotic resistance is increasing, what should be the steps taken by government or our very own fraternity?
So, charity should start at home. So we should be careful of not only using only when required, use the narrowest spectrum antibiotic, use it with the correct dose and the correct duration. Don't stop an antibiotic halfway around, and do not use antibiotics which are sort of reserved for other more difficult conditions like tuberculosis or say enteric fever, which you should not use for other common conditions. And do not use very new, just because they are new and high-end antibiotics, that you should start using. We have all been managing these conditions without those antibiotics, so there should be no rush to have a dire need of the same.
Dr. Shirsagar is asking with paracetamol and ibugesic, sir.
Yeah, so if both were given at that time, I would think ibugesic is a culprit and try paracetamol alone, and vice versa. But even after that, if I'm getting an articulated rash clearly after the medication, I'll be left with no choice but to give only sponging. Some people have this concept that you can give an antihistamine and then give the medicine and then you won't have a problem, which unfortunately doesn't work for drug reactions.
So we can take the last question for tonight. It is from Dr. Dwivedi. For non-toxic appendicitis, medical or surgical treatment, which one should be preferred?
So I don't understand what is non-toxic appendicitis, but I am assuming you're saying a child with appendicitis who is not very toxic. So this decision is generally taken by the surgeons after doing a sonography or preferably after a CT scan to see what is the impending danger of rupture versus non-rupture. So if you think that this can be managed with antibiotics, they would rather do what would be called a cold appendix removal rather than an emergency appendicitis surgery, appendicectomy surgery.
So with that, I like to thank sir for taking so many questions from our doctors very patiently and answering them very patiently. Thank you once again for this wonderful lecture, sir. The cases, everything was very interesting and very evident that our doctors really loved it. Thank you once again. It was lovely having you, sir. Thank you, sir.
Thank you, Barsha. Thank you, Medflix, and thank you, everyone. Good night.